The hard part is that there are no studies of which I'm aware showing clear, unequivocal benefit to private equity investment in healthcare. There are neutral studies. There are studies that either hint at or show harm, but there's nothing that shows sort of unequivocal, incontrovertible positives.
Private equity and healthcare, two terms that don't really sound like they naturally belong together. But private equity has been acquiring a growing share of US healthcare in recent years. Current estimates put private equity ownership at over 8% of all hospitals and over 22% of all for-profit hospitals. Private equity firms have also purchased many private practices, physician practices, nursing homes, opiate treatment centers, and more. Should we care about this? How does private equity affect patient care? How does it affect the well-being of employees who work in healthcare institutions? And how is it affecting the healthcare landscape at large? Hi, I'm Derek Angus. I'm a physician and senior editor at JAMA, and you're listening to Healthy Dialogue, a new podcast from the JAMA Network. Today, I'm chatting with my friend and colleague, Dr. Sneha Kannan, an assistant professor in critical care medicine at the University of Pittsburgh and an expert on the role of private equity in healthcare. My goal is to try to better understand the complex and growing relationship between private equity and healthcare. Welcome, Sneha.
Thank you so much for having me. I'm so happy to be here.
So, when we think about private equity moving into healthcare, the first thing that goes through my mind is, well, in the absence of private equity, who currently owns healthcare? What's the traditional way that we've structured or financed healthcare, just to sort of level set?
So healthcare has undergone some dramatic changes in the last few decades. So it used to be a doctor would just hang up a shingle with their name on it. They would have a practice. They would own that practice. So they would be responsible for the costs of providing care, and then they would pocket all of the revenue in the form of profit, less their expenses. But things are quite a bit more complicated these days. Practices have merged with each other. They've merged with these larger systems, what we term consolidation in healthcare. And an important point is when it used to be the shingle, the patient would be getting care from someone who is not that far up above them. It would be the person who owned the practice. But now, the decisions that affect the patients are being made many, many levels above the bedside. And that organizationally can get very, very complicated. These parent entities, they can be very large companies. They can be bought. They can be sold. And these organizations may be nonprofit. They may be for-profit, which changes how the dollars that come in can be spent legally. And so ultimately, these structures are so complicated. And who gets the money has changed quite a bit. But as far as who pays the money, that part's still the same. It's still patients, usually through an insurance company, but sometimes out of pocket.
So last I looked, it's about $5 trillion a year we're spending in healthcare. That's across about 6,000 hospitals and about 1 million doctors. And of those 6,000 hospitals, the majority of those, about 4,000 of which are acute care hospitals. And all of these hospitals are being increasingly consolidated into networks, as are physicians. Physicians are equally getting consolidated into larger physician groups. So if we're going to start then talking about how private equity moves into this, could you just start by giving me a little primer on what private equity is?
Right. So private equity is this really broad term. I think one of the things that happens in reporting is private equity is used as a buzz term as if it represents this monolithic entity, and that's not really the case. Broadly speaking, financially, private equity, when you break up that term, just means private and equity, which is just private sources of money in comparison to public sources of money. So public sources of money could come from the government, so sort of like a public entity, quote unquote, or the people. And so the SEC will monitor a company that has an initial public offering or IPO where the shareholders are common people like you and me. And that's another source of public financing. Both of those, and public financing in general, is heavily regulated. Private financing operates under a very different set of rules. And these are companies that take money from wealthy organizations and individuals, example being a specific individual, a pension fund, a university endowment, sovereign wealth funds. All of these entities have money and they need somebody to invest that money and manage that money for them. And that's where the private equity companies come in. Private equity has been around for a while. And so part of the appeal of private equity in general was to bring operational expertise and to try to make the business lean, whether it's to trim costs, improve efficiency. And a very famous example of private equity in recent-ish years is Dell. And so in 2013, Dell was taken private, as in it was a publicly traded company with shareholders, and it was quote unquote taken private by Silver Lake, which is a private equity firm, and Michael Dell, the founder. And that is a success story of private equity in that Dell was struggling as a company, and Silver Lake came in and saw operational efficiencies and a way to bring excellence to Dell, and they took it private, and Dell is doing better. And so that is sort of a very famous private equity, sort of a very famous private equity story.
So Dell was publicly traded, and they basically wanted to say, we'll buy the whole kit and caboodle. We'll stop trading it on the stock market. It'll no longer be a publicly traded company. But we're only going to do that because now that we own this thing, we will then get to run it in a way that we think will make it more profitable.
Correct. So that's the incentive on the private equity side. And this whole phenomenon, the deal that I just described with Dell, is called the leveraged buyout. So a leveraged buyout is a way to take control of an entity that is largely financed by debt. I think of it a little bit like buying a house. This is not a perfect analogy, but if I or many Americans want to buy a house, they will often do that using a mortgage. And a mortgage is debt, right? The leveraged buyout is different because in the mortgage example, I, as the homeowner, home buyer, is taking on the debt. In the leveraged buyout, the actual company or the house in this example is taking on the debt. And why does that matter? It matters because the profits that are generated by the company or the house in this example no longer exactly go to running the business or even go to what they were being put towards before. There's this new purpose for those profits, which is to pay down the large amount of debt that was required to make the purchase.
So let's join the dots here. Now that we have a basic understanding of what private equity is, how has it been moving into healthcare?
Right. So healthcare and PE has a long history. I would say it started again in about the 80s. And private equity has entered healthcare sort of sector by sector. It's not entirely linear, but hospitals and physician practices were first. And the competing forces in the healthcare system have fueled this a little bit. So, for example, as specialization has become a huge force in healthcare, where these practices are entirely dedicated to dermatology or ophthalmology. I use these specific examples because private equity penetration in these is relatively high. Private equity has seen that there is money to be made. In America, healthcare has always been a very cash flow heavy, lucrative business. And I say that because, unlike some other sectors, healthcare is what we call price inelastic, in that if I'm sick and I need healthcare, I'm not going to stop and shop around and look for the cost of goods or to see which hospital is charging what. I'm just going to go get whatever emergency care I need. Or if I need to see a primary care doctor, likewise, I'm also not shopping around to try to find the one that charges the least. What does this mean? It means that healthcare is a business that will always generate money because people will always use it.
So can I just ask a little clarification there? So I can definitely say that, hey, people will always be sick. You'll always need healthcare. But my understanding is the game here is about profit. So for example, when you tell me that private equity wants to buy up dermatology practices, I could imagine that because of the way dermatology is financed and what people will pay for, you might be able to provide a dermatology service where you're paid more money than you're spending, so there's profit. But we hear all the time about healthcare or hospitals that have sort of razor-thin margins. You know, they're obliged to take care of patients. They take care of someone with severe sepsis. The government pays them X number of dollars, but they spend X plus Y dollars taking care of them. And all those Y dollars are putting them in the red. So what I'm not quite understanding is why would private equity, and I think this is the case, but why would they be interested in something that, although they're being paid money, they're spending money faster than they're making money? Like, what's the angle on how you're going to make money?
So what's in it for them, right?
Yeah.
Like, why are they doing this? So depending on the sector of healthcare, the margins are very different. So I'll start with that. But hospitals are a great example because they do have low margins. But where that benefit comes in is I mentioned that healthcare is a cash flow heavy business, right? We know it will generate money. The question becomes, can you deliver care? And in my world as a physician, in your world as a physician, the goal will be to deliver the same or better care. But let's just say, can you deliver care to patients for less money? And this is the theoretical benefit of private equity. I told you earlier about operational efficiency. In a hypothetical world, what if they could acquire a hospital, fold it into their larger system, and negotiate better prices for contracts, bring in new technology that the hospital couldn't afford before, but now can, improve training for physicians and staff? Those sorts of operational efficiencies, in theory, could reduce costs and increase the amount of revenue by perhaps providing novel services. And when you either decrease costs and or increase revenue, you have increased your profit. And that, I think, is the selling point for private equity.
Okay, so that's the selling point. But what did the data show about the impact of private equity on healthcare?
So I'll go through a couple of the sectors that we know because the physician office with the shingle above the door operates very differently than a hospital, for example, or a hospice organization. So physician practices, we have seen private equity investment across a number of different specialties like dermatology or ophthalmology. Additionally, in infertility or fertility clinics is another place of private equity investment. Where those have happened, what we have seen characteristically is that staffing changes are made in terms of training level. So, for example, there will be fewer physicians hired and they'll replace physicians with physician extenders. There has been research in physician practices that pricing goes up. There is research coming out about closures, about whether or not physician clinics are more likely to close under private equity. In hospitals, what has been shown is that staffing somewhat uniformly is reduced. There has been some evidence about changes in what we call payer mix, which is the type of insurance that comes in for the patients that are treated. So there have been decreases shown in Medicare and Medicaid and variable increases in commercially insured patients. How that translates to money is commercial insurance reimburses better than the government in Medicaid and Medicare. The staffing cuts have been seen across different firms, different hospitals, as well as most departments. And that is now starting to be tied to changes in quality. So we showed that there were increases in hospital-acquired complications, as well as increases in mortality or the rate of death for patients treated in the emergency department, and the rate of transfers out to other hospitals for patients treated in both the emergency department and the ICU. There are now starting to, by very talented colleagues of mine, starting to be papers published on the quality of care in the outpatient setting, in the physician practice setting. That is a little bit harder because the quality reporting infrastructure for physician practices is not nearly as robust for hospitals. There have also been an extraordinary amount of great work done studying private equity acquisition of hospices, where ultimately patient and caregiver satisfaction goes down, and the amount spent on each claim is thought to go up. That's preliminary.
So it's everywhere, and on average, although there could be theoretical advantages, on average, the findings suggest that as they've invested, they appear to be prioritizing profits over other aspects of healthcare delivery, with adverse consequences for things like payer mix, staffing levels, care satisfaction, and caregiver satisfaction and quality of care. Is that right?
I agree, but I should quickly highlight two papers. One was studying fertility clinics, where private equity investment was found to increase the rate of live births, which is a good thing. However, that paper also showed that the mechanism by which that happened was by bringing more women into the clinic. The actual rate of live births for a woman coming in, the likelihood of a chance of live births did not change. It's just more women came in, so more babies were born. There was another paper that was published a couple months ago that ultimately said that there was no harm to patients for private equity investment to hospitals. But I would just caution interpretations of that from that paper, because that paper studied things like mortality in a limited number of conditions. The hard part is that there are no studies of which I'm aware showing clear, unequivocal benefit to private equity investment in healthcare. There are neutral studies. There are studies that either hint at or show harm, but there's nothing that shows sort of unequivocal, incontrovertible positives.
We'll link to papers Sneha mentioned in this episode's description, but I wanted to highlight one in particular, a 2023 paper written by Sneha and her colleagues, published in JAMA, entitled Changes in Hospital Adverse Events and Patient Outcomes Associated with Private Equity Acquisition. It's a highly cited paper on the subject, and it is definitely worth a read. As we continued our conversation, I wanted to really dig into the motivation for private equity investment in healthcare. Why would PE firms want to invest? As anyone who's worked in a hospital knows, the idea of providing quality care at lower cost is not new, and it's not easy. And so I wanted to know, why is it that private equity thinks that they have some secret sauce that prior owners of healthcare organizations didn't somehow have access to already?
I think, your question is an interesting one, but it gets at lower costs for whom, right? And so I totally agree that we have been scratching our heads as a healthcare system for decades, trying to reduce costs, but to whom, right? It's to patients usually, right? Via insurance companies, via the very complicated payment structure by which money flows from patients' pockets into healthcare systems. But I would hazard that private equity's goal is not that. They are not necessarily trying to rein in costs for patients. And so now all of a sudden, the motivator you mentioned and the motivator I mentioned are no longer in tension because they're just different.
Okay.
And so that's the hard part. And I will say one other thing, which is that what we're seeing more and more in the research I and many of my very talented colleagues have done is that it is indeed incredibly challenging to provide the same or better care with less. The margins in healthcare are already so thin, and people, providers, caregivers, anyone who works in the very large net of the healthcare system, they're already stretched so thin that trying to ask them to do more with less is almost an impossible ask.
Okay, but that is what they're effectively going to be doing. The one way or another, they have an angle, and the angle is that they're looking to make money. They're trying to grow the equity. From investing equity in one place, they hope to get a rate of return that would be more favorable from spending the money here than them placing the money elsewhere. So they have some angle.
They do. And one question I have, as I don't work in a private equity firm, I don't have extreme visibility into their motivations. But one question and one concern I have is, with the incentive to make money, how do they think about the incentive to provide care? Are they prioritizing the delivery of care that is as good or better than it was before, alongside their incentive to generate profits? But another difference in private equity's operational model is they enter a business already thinking about how they're going to exit it. And so if you think about your local university, for example, buying a hospital, and the system that I work for example, is quite large, their goal is to buy the hospital for keeps. Whether or not they keep it, I don't know. It depends. Sometimes they sell it, sometimes they close it. But private equity in general, their business model is such that they are looking to exit somewhere on the order of 3 to 10 years when they make the purchase.
Okay, so a group with private money represented by some organization, a firm that's a PE firm, along with some people or banks who are going to provide some financing that would effectively become debt, see some healthcare system and they decide to buy it. And they're thinking, let's go buy this thing. Then we're going to do things for a few years and then we're going to turn around and get our money back out with profit. That's roughly right.
That is correct.
And one of the things they're looking to do is to say, we'll come in and we'll install our own management team that will trim costs, lay off people that are working inefficiently, contract with services to like lower drug costs or whatever, save money on supplies and do various other reorganizing things, match the number of beds to the number of patients better or whatever. And then do they also do something sometimes with the real estate? Like I've heard that they sometimes divide the hospital into, there's the part of the hospital providing the services, and then they create an entity that owns the land that the building is on. Or could you explain that better? Or
That is both, I think, made it into the news because of a couple high-profile bankruptcies, but it's also more ubiquitous than I think some people realize as a strategy. So what you're describing is what's called the OpCo-PropCo. It's a jargony term. I just like it because it sounds funny, but it's the operating company and the property company. But the short of it is exactly what you said. So when hospitals are bought, they can either be bought with the land and the building, or simply the operations of the hospital are transferred. Sometimes, if a hospital company is not leasing it from the government or another entity, they will own the land and the building in which they are operating. One way in which to generate short-term profits is to sell that land. You maintain the operating capability of the hospital, but you sell the land the building sits on, plus or minus the building, to another company. And all of a sudden, you've generated millions of dollars in short-term income, right? But you still have to somehow get the building back because you're operating in it. And so you will lease it from the company that you've sold it to. So that's also called a sale leaseback. And so you sell the land and then you lease it back. Where can this be a problem? And I have a couple colleagues who have done fantastic work on this actually very recently. You run into problems in that the company that you sold the land to can now jack up the price of that land. You used to own the land. You didn't have a lease expense. And now if you get rid of the land in order to generate short-term income, you now have to pay a lease. And depending on what the cost of that lease is, that may or may not be tenable or financially feasible for the hospital. This was a rather prominent part of the story of Steward Healthcare and its bankruptcy earlier this year. It is also part of the story of many other private equity firms, because if you look up sale-leaseback, you would see that many private equity and other for-profit operators use this as a way to generate profits in the short term. If a company is incentivized to generate profits in the short term because they know that they're not planning on holding on to this operation or property or company for the long term, then you run into issues where the next operator is unable to pay perhaps the very high lease costs. And that is what happened with Steward. And so this is the sale leaseback, the OpCo-PropCo. It's been seen in hospitals. It was also seen in nursing homes. It's also seen in sectors that are not healthcare. This is sort of a known strategy by which firms can generate returns for their investors and their partners. And sometimes I'm sure it's completely fine. The ones that make the news are the ones where it's not completely fine, and you see the downside of operating like that. And so what you're saying is a known phenomenon across sectors in both healthcare and outside.
So it's quite easy to sort of see potentially scary stories about where this might not go well. But let's just step back for a second. Financing healthcare is a hell of a job. You know, we in every other country, in every high-income country, is constantly fretting over how to finance healthcare. And so looking at this from a positive standpoint, the fact that private equity wants to invest in healthcare on its surface feels like that could be a great thing. And you started with a beautiful example from outside healthcare about Dell. And Dell seems to be quite a thriving company today. And I think we all remember that Dell looked like it was about to go away. So if that's due to private equity, then, full marks. That's great. So could you just either give an actual example or a theoretical example of how this all can go really well for healthcare with private equity?
I think a lot of the lessons that have been taken from other sectors may be applicable. And I will theoretically say the benefits of private equity because the research is still new. And frankly, we have not yet found a strong example of private equity being a force for good. The research has either shown detriment or it has been neutral. And so I'm eagerly awaiting an opportunity to see where private equity could improve healthcare because, as you said, private equity has penetrated rather deeply and it's here to stay. So, as far as the theoretical benefits, a lot of the ones I mentioned earlier, such as improved negotiating power with vendors and suppliers, bringing management and operational expertise to a business. Healthcare is an interesting kind of business, but it is a business, as well as understanding accounting and financing principles in a way to try to find potential avenues for either lowering costs or increasing profits, bringing in new technologies from other sectors. A lot of the private equity companies that own hospitals are large and invest in many other different sectors. And so providing sort of liquid capital that can be used to acquire new technology, improve training, bring in new service lines, increase service lines, all of those are potential ways in which private equity could benefit healthcare and has benefited other sectors in the past.
Right. So private equity is definitely here to stay. And in a field troubled by lack of investment, it's a source of investment. So those are positive developments. But I think you're overtly concerned about whether the incentives are aligned. And I think if I'm reading between the lines, it's also hard to know because there's a relative lack of transparency. Is that right? And when you talk about regulation, that usually comes part and parcel with greater reporting and transparency. Like you can't really regulate unless you can see. So
That is very true. And that is a particular challenge because healthcare operates within the American economy, right? And so in some ways, healthcare is regulated like any other business sector. In other ways, though, healthcare is regulated more than other business sectors because there is this goal of patient care beyond just profits. And that's where I think the strength of regulation lies. And to your point about transparency, one of the things that's challenging is that private equity is not required to disclose a lot by virtue of being a private source of money and not a public source of money. That is true in other sectors. That is also true in healthcare. So the question becomes, what exactly would we like transparency on, and how do we get it, given the constraints of the American economy and its legal system that we currently work under? The nice thing about healthcare is that the deals are more scrutinized, and they're increasingly scrutinized even now as a result of these very high-profile bankruptcies in the last couple of years. And so the best place, I think, to focus our energy is at the time of the deal. Some of these acquisitions meet certain reporting thresholds by virtue of their size. And so some of this information is required to be disclosed, like who is going to be the holding entity. Many states, not all states, but many states require state attorney general approval for these transactions to go through to, again, ensure patients are protected and that there's not a lot of anti-competitive behavior. That's at the state level. The federal level is usually the FTC. These approvals by the state AGs offer opportunities for conditions to be placed on these sales. And one can see this happening more and more in the past several years, where, for example, staffing levels are mandated for some number of years. Maintaining a certain amount of expenditures on capital improvement, i.e. building improvement, maintaining seismic compliance in California, for example, or ensuring that facilities stay up to date and safe, as another example. These can be part of the regulation around the deal. What becomes a little bit harder is trying to understand the exact financing of these deals. The Dell deal, for example, there have been business school and think tank case reports on this, so that deal structure is public. Something of that size, usually the deal structure is in some way public. The problem with healthcare is For example, in hospices where acquisitions have accelerated since COVID, a lot of those deals fall below federal reporting guidelines just in terms of size. And so it becomes hard, I think, to require reporting in healthcare in that way when no other sector requires reporting in that way. And this is what the issue becomes with private equity. And so to me, in summary, we do need transparency. I think we have to work within the existing frameworks. And so the larger deals will get more transparency on the actual financing structures. However, the part that's good about healthcare is that we do have a framework for regulating patient outcomes and things that we know affect patient outcomes. And so even if we don't always understand exactly what the owners are doing in the background or how the owners are going to pay for whatever acquisition they're about to make, we do have a sense of what things affect patients. It's something that I also encourage researchers to focus on is tie this back to patients because that's what matters, right? At the end of the day, that's what healthcare is here to serve. Healthcare is here to serve the patients. But even from a goal of regulation, from a goal of trying to better understand and then sort of guard and rein in some of these perhaps more profit-seeking behaviors at the expense of patient care, the way to do that is to understand exactly what does affect patient care and then try to leverage the avenues you have to regulate those.
Okay, so bringing this home a little bit. So first of all, I have one question about regulation and then one wrap-up question. So it sounds like PE is here to stay. It could be a force for good, but there are certainly notable examples that certainly gives one pause. And I think you're alluding to the point that the kind of healthcare you get is absolutely dependent on who owns the healthcare delivery. And we might not have that much transparency on who owns it, but we could still transparently report the outcomes as a sort of, that would be a little bit like getting reporting on the performance of the car you want to buy or something like that. Some reassurance that the healthcare delivery organization you're going to provides high, good outcomes and so forth. So my question is, does our existing sort of quality reporting standards enforced by Medicare, et cetera, is that all we need, or has there been a vacuum from the federal government and such that, for example, individual states have said we need more and have tried to impose greater regulation or oversight? And if so, is that causing a backlash, or where are we with that?
It's a great question. So there are existing quality reporting requirements for, as you said, that CMS, the Center for Medicare and Medicaid Services, places on. Hospitals are perhaps the best example. There is quite a bit less reporting involved with physician practices. And I don't want to say that's a problem necessarily. It's just a point of future work. Like, how do you assess the quality of these smaller practices? I'll speak on hospitals because there is an infrastructure there already. So what we would have to do is marry that infrastructure with the idea of ownership. And it turns out a lot of ownership is actually publicly reported in the hospital space because these deals are big. And hospitals treat thousands of patients. And so if something happens, it makes the news. And so if one were to combine those things, one could evaluate quality alongside changes in ownership. And I think that is an avenue for future research that I and many of my colleagues are pursuing. Stay tuned. It's going to be a little bit until we get results, but the fact that we have quality reporting already there is something we can leverage. Now, as to what the states are doing, as I mentioned, the federal levers for this are smaller, and they also change sort of based on the nature of the government and what the priorities are. State levers tend to be a little bit more consistent, and there is a lot of variation. There have been bills that have been introduced in many states. I think the most assertive about regulating the ability of owners to influence the quality of care comes from Oregon. And Oregon passed a bill through the state legislature recently very explicitly limiting the ability of the owner, private equity or not, to affect things that directly impact patients. So, for example, staffing levels or the ability of the parent organization to make changes to billing or changes to clinical practice down to the provider level. And I don't know what the future of this bill is going to be. It's likely it will go through some litigation, and I'm not sure exactly when or how it would be implemented. But other states are going to look into this bill as an example, perhaps. And the one thing to bear in mind, and this is true of private equity in general, is there's a lot of variation between states. Private equity investment tends to be concentrated in certain regions of the country, in part because the laws in that state perhaps are favorable to that kind of investment or disfavorable to that kind of investment. The regulation is going to follow the same kind of pattern, I think. But what will be interesting is that states like, for example, Oregon, who have passed these laws, if they are implemented, can provide an example to other states who, if they have a lot of private equity investment or other types of for-profit or even consolidation that they're concerned about, it provides an example for them to draft their own legislation. And it does seem to be that states are where the regulation is happening right now. It's just harder to do that on a federal level because, again, a lot of these deals are approved on a state level. So that's where we are right now. It's still early years yet. I think a lot of the attention was brought on this very recently, even though private equity has frankly been around for a long time. But it's good that now people are paying attention.
So this sounds like we're not going to solve that on this podcast. This sounds like a classic tension that has played out in many other industries between sort of pro-regulatory and anti-regulatory forces, people advocating for you get a more dynamic and healthy market if the government keeps its hands off and doesn't overly regulate. On the other hand, some would argue that in order to ensure consumer protections, which in this instance is quite real, it's actual patients, one needs more transparency. It's probably not going to be solved right now. What does that mean if you are sitting at home listening to this as a prospective patient or as a physician or a healthcare provider?
So what can the members of the community do, right? Regardless of their role in healthcare. So as is true with all things in our democracy, is to vote, right? We speak with our vote. But that is rather removed. And I think in a world where these deals are happening in real time, often before many folks realize they've happened, what can people do? And I would say this is just very practical advice. As you said before, and as I firmly believe, when one gets healthcare from somewhere, it matters who owns that somewhere. It matters who owns the healthcare entity because that's where business decisions are coming down. And if your business is providing care to patients, those business decisions will affect patients. So as a patient, I would say pay attention to whether or not where you get your care is changing ownership. If the ownership change is likely going to come with changes in staffing or changes in service lines, as a patient, have a backup plan in place. Make a backup plan so that at the end of the day, you have more control over what happens to you as opposed to the entity that may be many levels above your bedside. Certainly on the physician-provider side, there is more and more research coming out about how, on average, some of these buyouts affect practices. And I would recommend these physician and provider owners educate themselves on what could happen. And ultimately, if that aligns with their goals for their own practice. And to me, it's all about education. I think with time, with more information, more research, with votes, there is a possibility of regulation, but that is removed. Even under the best case scenarios, that is removed. And so in the meantime, I would just say educate, educate, educate.
We'll end on that note. As always, you can find a ton of resources and research about this episode's topic in the episode description and associated article on JAMA.com. Thank you to my guest, Dr. Sneha Kannan. And if you have questions or comments, let us know at healthydialogue@jamanetwork.org. We'll try to respond in a future episode. This episode was produced by Daniel Morrow, Matthew O'Connor, and myself at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved. including those for text and data mining, AI training, and similar technologies.